Just a few cases sometimes which, take our breath away. This is a 29-year-old woman, unmarried, has generally had regular menses, and she now presented with sudden amenorrhea for 2 months. No other major symptoms, no systemic symptoms, and there is nothing really on examination except that her mother is worried that she has suddenly had amenorrhea. The gynecologist actually ordered the following test, which I have put up for your knowledge. This is TSH was 3.7 normal, her FSH was 0.2 MIU per ml, which is low obviously, LH was 0.6, prolactin was 57 nanograms per ml. Now at this point of time, this report went back to the gynecologist, and she told the mother that, look, we have the diagnosis and she has got a prolactinoma, and the MRI was done and the pituitary showed a 3 millimeter lesion in the right half, and everyone was happy. And this girl was actually referred to a neurosurgeon to decide what to do, who then decided to refer to me, because he obviously explained to them that 3 millimeter tumors are not operated upon. And what would you do in this scenario? Sorry? History of? Yeah, so the drug history was taken, agreed. So drug history was negative. Yeah, I agree with. But here the FSH LH is also low, which may not happen in a drug induced hyperprolactinemia. Yeah. Sorry? Pooled sample. Okay, you could do a pooled sample in this case, but let me tell you, the pooled sample returned the same value. So it was 57. Sorry, ma'am.
No, it's okay, nothing.
That is what I said yes in my talk today morning also. The most important cause of amenorrhea is still pregnancy, and this girl was pregnant. No, I'm not joking. This is a real life case. We sometimes forget to do a PT in amenorrheas. It doesn't matter. Agreed, completely agreed. It came, and actually it was a shock to the parents when we told her that this is the diagnosis, and then of course it all came out. But what I'm trying to say is that this is a typical report of early pregnancy. A low FSH-LH, a slightly high prolactin, and amenorrhea. So don't necessarily go by prolactin values is what I am trying to figure out from this particular case. So an eye opener, don't go by marital status, don't go by previous history, don't jump to conclusions only by one single hormone report. So that's important. Pregnancy is still very important. All right. I'm not joking, it would have clinched the diagnosis. This is a 43-year-old female. Basically, she was seen for progressive weight gain of 10 kilos over the last 5 years. There is no personal or family history of any specific abnormal illness. TSH is 3.1. She talked it over with her doctor, and she was started on 50 micrograms of thyroxine. No change in weight, and dose increased to 100. The TSH is now 0.06. No symptoms. What would you say this is? Sorry? Could you speak up? I mean, I don't think the audience will.
10
Again,
kg,
a very.
10 kg in 5 years is not significant. I mean, for a
don't
female.
think so. My gosh. Try explaining that to the patient. No, it is significant. I mean,
But for no reason. Like if the appetite is increased or maybe pregnancy or.
we don't know. But she has gained weight progressively. There is no doubt about it. That's all different. We are now talking of what is all happening here. See, this is a very common scenario. Now, as I was cautioning yesterday, this would be seen in the lab and it would be labeled as low TSH query primary hyperthyroid. What this lady is getting is unnecessary thyroxine. This is thyrotoxicosis factitia, with no relationship of a thyroid status to her weight. So this is all made up, actually, made up by doctors. So she didn't have anything in the first place. She was put on thyroxine. Her weight obviously didn't go down because she had no hypothyroidism. Then in the belief now that thyroxine will cause further weight reduction, her TSH was not even looked at, and the dose was progressively increased in the hope that this will cause weight loss, and this didn't happen. So now somebody did a TSH, it is 0.06. I hope she goes to someone sensible, otherwise she will now go on to carbimazole therapy, and this will go on for life. She will alternate between thyroxine and carbimazole, and this nonsense will continue. So idea is, when what I said yesterday also, that as pathologists you have the right to ask what the patient is on before any kind of report interpretation is made, because only thyroid interpretation doesn't mean anything. This is a 32-year-old female, underwent surgery for a large pituitary tumor, and the pituitary tumor was found because she had headache and visual symptoms in the first place. She was evaluated at length in the beginning. No specific hormone abnormalities were detected preoperatively. So probably she had a non-functional pituitary mass, and for the mass effect she underwent surgery. Post-operatively there was still a residual mass, so she underwent radiation as well. She was investigated approximately 2 months after the radiation was finished, because by that time she had developed amenorrhea, which is quite common after surgery and radiation, and weakness, and she was found to have a low FSH and LH and low cortisol. The serum cortisol at that time was 3.2 micrograms per deciliter. This was in the morning, unstimulated, not post ACTH value, single value of 3.2. She was not on any medicines at this point of time. So what would you say to this right now? She is developing hypopituitarism very clearly. Her FSH LH is going low. She is developing amenorrhea. Her cortisol axis is also going low. Her thyroid at that point of time was normal. Okay, I have not put it here. Now, she was started on estrogen and progesterone, and tablet Visolone, which is prednisolone, was started 5 milligram once a day. Subsequently, then she started to follow up with a neurosurgeon. She started getting her periods, and after going back to the neurosurgeon, she had a repeat cortisol test to assess what is going on, and the repeat cortisol level was actually 1.8. It was 3.2 earlier, it was now 1.8 micrograms. So she was asked to increase the dose of her prednisolone from 5 milligram once a day to 10 milligram once a day. 3 months later, she was called back for a repeat cortisol value, and the cortisol was now 0.7 microgram per deciliter, and the dose was increased to 5 milligram 3 times a day. And this is what happened when this lady came to me about 6 months later. You think this is Cushing's? Yeah. So what is happening?